this wonderful necklace that my father, who had a major heart attack in his early 60s, gave me. This, you can't see it from there, but it's a reproduction of a cave painting of a horse. And I thought, we've always called in the cavalry when we have a major fight that needs to be fought throughout history. And what we have in Pharmacists, in my view, is a fantastic cavalry that we have not called in. And so I want you to just remember that if we can bring in this powerful, muscular force to bear, to add, as we have shown for many years on this very beat-up poster, my wonderful Megan pointed out, hey, this thing is really getting old, can't we update it? I'm like, well, not till after this one, because I want to point out that, yeah, we've been using this poster since 2008 or so, and we've always been recommending the pharmacist on the care team. And so I would just encourage you all to think of the pharmacist as the cavalry that you have not yet called in to bear on the task of preventing cardiovascular and diabetes, death and disability and family misery that results from that. So I just have to say thank you so much, Jan Hirsch, for being our initial co-principal investigator of our National Institutes of Health grant that helped start the University Best Practices, our pilot project, which has been published now as having reduced expected MIs in our first pilot community by 2,735, and that if those results were spread throughout the state, it would have saved more than 22,000 heart attack hospitalizations, an unknown number of deaths, although we have some physicians here who can elaborate on the mortality data as well. So I just am going to turn over the mic to our chairman, Bill Baumer, and just thank you for being here.
Again, thank you very much for attending today. For those who were here early and saw the YouTube video from Stanford, let it be known that we are going to prepare our own YouTube video. We would like any volunteers, anyone out there who has talent, please let us know, because we could use you for our own YouTube video to strike back at that and go for the axe, as they say. We're happy today everybody is in attendance. Thank you for showing up. I know you were all up late last night watching the meteorite shower, the Perseid shower, which peaked last night. Don't worry if you missed it. We have a few meteorites here today to make presentations, and you'll be outstanding star shower that you'll see today for their presentations. We spent a little bit of time preparing this because RightCare is really interested in the participation that pharmacists can add to healthcare and healthcare improvement. And so you'll notice today's program is pharmacy priority, and we're happy to lead with that. And to start out with that, we're going to have Susan Ivey, who is going to present information about the role of pharmacy and the lead for it. She is on the faculty at UC Berkeley, and we're happy to have her here to start off our pharmacy day at RightCare.
Spread out on my little notes and things here. So welcome. Hopefully everybody's excited to be here today. I get to tee up this presentation and be the moderator of the panel today. Our panel is going to update us on pharmacists on the care team research, both published research and research in progress. Most especially, I want to say thanks to Dr. Jan Hirsch, who put together the Southern California presentation for LABDP, and it was so well received down there that we decided we wanted to bring that presentation up here today, and that will review her recent work and that of her colleagues, and also we're fortunate to have speakers from both UCSF and UC Davis here today, and I'll introduce them in short order too. So I'm just going to talk a little bit about the brief, and I want to point us to that brief on your table. If you can look there on your table and find the one that looks like that, that's what we're going to take a look at first. And I'm not going to go through everything, but I'll have a slide up here that we can look at too. Is everybody hearing me okay? So our speakers today are going to be Dr. Jan Hirsch from UCSD, Dr. Stephanie Roberts from UC Davis Health System, and Dr. Rose Pavlakos from UCSF Department of Clinical Pharmacology. And I want to do a disclosure that there aren't any relevant financial relationships with commercial interests as far as we know. Our objectives today will be to understand some of the new evidence regarding clinical and economic benefits of adding pharmacists to the care team, to review our new Pharmacists on the Care Team brief, to describe our recent Pharmacists on the Care Team projects in both Southern and Northern California, to discuss collaborative practice protocols between physicians and community pharmacies, and to highlight some of the policy challenges in our environment. So our brief was updated in May 2018 to include some new research studies demonstrating positive outcomes, especially for cardiovascular conditions and hypertensive care. Although pharmacists on the care team is certainly not limited to those conditions, has been used in a number of other conditions successfully. We've updated it to include work of our research pharmacists who are affiliated with RightCare.Initiative, both Dr. Hirsch and Dr. Steve Chin, who couldn't be here with us today. It highlights some newer estimates of costs of non-optimized medication therapy from Watanabe and Hirsch and UC San Diego. It will also feature information about pharmacists working effectively in a variety of different settings, inpatient settings, transition from hospital to home and other settings, working in community pharmacies, assisting with telemonitoring of patients, and out in new community settings like barbershops. So I want you to take a look at your, sorry, that went too fast, at the top of the brief on what is your left side, my right side, that says a need for improved medication management. So as Hattie said, the pharmacists on the care team is a way to sort of bring in the cavalry, and one of the reasons we need the cavalry, sorry, this is really touchy today, is because of the very high costs related to non-optimized medication therapy. So Watanabe and Hirsch did a calculation. I must just be like not handling this. Sorry. Maybe I just won't touch it in between. I'll only touch it to advance. Wanted to calculate the cost of illness and death that results from non-optimized prescription medication therapy. Previous analyses have been done like this. However, they included some additional new costs that looks at problems that come from medications that are new medical problems, as well as problems that happen not just related to non-adherence, but not taking your medications optimally. And that figure, $528.4 billion, or nearly $500 billion, is equivalent to 16% of the total healthcare expenditures in 2016 dollars. The prior figure was $290 billion, frequently misquoted, but didn't include all of these costs that Dr. Hirsch and her team have now been able to look at. So adding pharmacists on the care team can help optimize medication outcomes, but also dramatically reduce costs, not just in our settings locally, but at a macro level for our country. And as I said, it can work for multiple chronic conditions. So a number of recent studies are on here that continue to bolster the evidence for clinical and economic benefits for adding pharmacists to the care team. A couple of the ones that I'm going to tee up are one that looked at a statewide program in the state of Hawaii, where they looked at hospital-based pharmacists who had special training, who worked closely with community-based pharmacists who also had specific training. And in this study, they looked at connecting those patients who were leaving the hospital who were at high risk for rehospitalization to both the hospital-based pharmacist and the trained community pharmacist in order to optimize their medications in that transitional care period. And not only was there a reduction in hospitalization by over a third, but there was also a savings of $2.61 to every dollar spent. So a very high return on investment for this program. $6.6 million of avoided costs in Hawaii. So this is a very cost-effective program that was implemented, in a small state, but one that we can use for replication for other states. Another study that comes from CBS Health, from Polinsky et al., was also an insurer-based transition of care program. They also looked at doing post-discharge pharmacist medication reconciliation. And that study showed a 50% relative risk reduction, 11% absolute risk reduction for hospital readmissions, not just ones related to medication, but all hospital readmissions within 30 days of discharge. And this program also more than paid for itself with a savings of $2 for every dollar spent. So you can see both of these are very, very cost-effective programs, and with this kind of data coming in are important ones to look at implementing for transitional care. Another one I want to highlight looks at telemonitoring. Increasingly, we're going to be able to use telemonitoring using our technologies, but also, as I'll cover at the end, we'll have some mechanisms for recapturing some of that cost. And this study looked at home blood pressure telemonitors, where the data were wirelessly transmitted to clinic-based pharmacists who were then able to adjust hypertensive therapy under a collaborative care agreement with physicians. This modern model of making hypertension management accessible and convenient was called something that could be taken to the bank, sort of like ATMs have become for banking. We used to go into the bank and pass our check across the counter, and somebody would get some money and pass the money back to us. So having remote blood pressure monitoring, home-based blood pressure monitoring, is a new technology that we can then move data remotely, as long as we have people at the other end who can actually act on those data with the training and knowledge to act on those data. And one of the things that I've been looking at with some of the groups in the Bay Area is how do we make that final connection? How do we get the data from the monitors, from the Bluetooth applications, into the hands of people who can make the decisions? And that seems to be one of those final glitches that we're going to hear a little bit about from our UCSF pharmacists too. Anyway, in that study, we were also able to show that blood pressure was not only controlled better after 6 months with the intervention, but also they maintained better control after 12 months. So 71.8% for control versus 45.2% in the usual care group. So some of the other studies I'm going to have Dr. Hirsch also talk about. She's going to cover our community-based studies, including a new study that was done in Southern California using pharmacists in barbershop setting. And so we're going to let her come up and cover some of the other studies that are on the brief. There are, on the front side, some other studies that relate to community-based pharmacists. And then on the back side, we have a study that's in progress in Southern California, as well as our old friend, the Asheville Project, that also has the older data on effectiveness of pharmacists on the care team. So, Jan, let me introduce you. So, while Dr. Hirsch is coming up, Dr. Hirsch is going to talk about collaborative care protocols with community pharmacists and physicians. Dr. Dr. Hirsch is a BS in Pharmacy, who has her PhD and a Fellow of the National Academies of Practice. She's also a Professor of Clinical Pharmacy and the Chair of the Division of Clinical Pharmacy at Skaggs School of Pharmacy and Pharmaceutical Sciences at UCSD. In addition, in her spare time, she's Executive Director of Partners in Medication Therapy, which is an outreach program for the school where pharmacy students and pharmacists provide MTM services in low-income communities. Dr. Hirsch's research interests are in the area of pharmacoeconomics and outcomes research, and specifically she's interested in assessing the full value, like this Watanabe study she did with Watanabe, of pharmacy services and pharmaceuticals, and doing observational studies across therapeutic areas to develop and integrate patient-reported outcomes like burden, elements, quality of life, and satisfaction. So, Dr. Hirsch, I'll let you take it from there. I'm not sure how but I'm not taking that.
Megan is going to help us.
Yeah, we were still doing this, full disclaimer, we were still doing this on Zoom last night because Dr. Hirsch's PowerPoint was not working and we were merging our slides together last night. So
Thank
we
goodness.
think this is all the right set.
We are going to see. So first off, thank you for inviting me up here. I appreciate it, to the co-chairs and certainly to Hattie for inviting me. We did do a similar sort of review at the LA University Best Practices last month, and Steve Chen, who is the chair of clinical pharmacy at the University of Southern California, also presented with me there. What I'm going to do is to give you an overview of a couple of studies. One that's that's hot off the presses, and it uses pharmacists and barbershops, and the results of this study were just quite amazing. And then I'm going to make you do a little work also. Also on your tables, you have a little survey. Don't do it yet because I'm going to ask you to do it when we get to that point. And hopefully that will move us on to some discussions about involving pharmacists more in a community base as opposed from an institutional base. Okay. So Hattie mentioned that I was involved in the original study that sort of kicked off the RightCare initiative. And I wanted to just say that this is one of our efforts in which we were first combining pharmacists. And in this case, this is on the your pharmacy brief also. But this was looking at pharmacists. Oh, you're right, you can't touch anything. Hold on. I won't touch that. What we did originally is we embedded the pharmacists into a internal medicine team. And this internal medicine team did not have a pharmacist before. And what we saw, our results were that we did see improved blood pressure control and also fewer PCP visits as opposed to the comparator group that we compared that did not have the pharmacist on the team. So we identified drug therapy problems were identified in almost 50% of the patients at their first pharmacist visit. That's a lot of people, right? And a larger percentage of patients receiving care in the pharmacist PCP collaborative practice had their blood pressure controlled, and on average they had 2 fewer PCP visits. And if you look over to the right, and I'm going to try to highlight this without going crazy here. Basically, in the pharmacist group, which was a pharmacist PCP collaborative care protocol, so the pharmacist was functioning under a collaborative care protocol, and the pharmacist could make changes in the medication, start medications, delete medications, order labs, etc. in that protocol. We had, after 6 months, 89% of the patients were controlled in blood pressure, as compared to the usual care group, which was PCP only, was 64%. And then after 9 months, we saw also a split between pharmacist group of 79% patients under control, compared to 48% under control. And I think this study really, at least at UCSD, it made some people sit up and say, oh, okay, how can we do this more? And so we've been working to do that more, over the years since this initial study. So also, the field of pharmacists and the evaluations of pharmacists in the literature now has advanced so much further than this study back in Yeah, so that's just kind of history where we came from. Now what I want to do is highlight a study that I had asked me to highlight. And this is the one where it's really incredible what happened here. These slides, so I have a big caveat here. These slides are actually from Dr. Ron Victor, who could not be here to present. Steve Chen, and when we presented this in the LA University Best Practices, he presented these slides, and I'm going to try to do it justice. Steve was more involved with Dr. Victor on the trial, so I did talk with him about some of the details, and I will answer as many questions as I can, but I won't be able to answer all of them. So I can go and take questions and for follow-up and get back to the group. Okay, so just basically, I think we know this, non-Hispanic black men, highest hypertension death rate in the U.S. They have less physician interaction and lower hypertension treatment and control rates than black women. And the question the study was designed to answer, are barbershops the right place or a really good place to improve hypertension control for these black men? So, the particular study I'm going to tell you about actually built upon a prior study that Dr. Ron Victor had done before. And in this study, effectiveness of a barber-based intervention for improving hypertension control in black men. In this study, what they did is they trained the barbers to provide education about hypertension, and also the barbers were empowered to remind patients to go to their physician for their checkup. So basically, the barbers were giving education and support, reminding patients to go to their physician. And the results were marginal, right? And marginal according to the authors, actually. And their conclusion was that the effect of BP screening on hypertension in this particular study was improved when the barbers became health educators, and they also monitored BP and promoted physician follow-up, but further research was warranted. So what Dr. Ron Victor did is then he implemented the second study that I am going to tell you about. And this was just recently published in the New England Journal of Medicine in 2018. I think it was April. And this was a cluster randomized trial of blood pressure reduction in black barbershops. So the idea, first up here on the right-hand corner, that these are only male patients, right? Females were excluded. So there were 40 barbershops, and these were in the Los Angeles area. And what they did is they looked at the baseline. There were 20 and 20, and the 20 and 20 barbershops, and didn't quite work out that way, but this is what they were trying to get to. And they were trying to get to about 15 patrons per shop. It ended up they needed a few more barbershops because the number of patrons per shop that enrolled was not as high. So I believe it was like 24 or 28 in the groups. And so there was an enhanced intervention, and this is where the pharmacist was actually in the barbershop and would have monthly appointments with the patrons in the barbershop. And the comparator was an active comparator, which the barbers in that group, in those shops, the barbers were still providing education about hypertension. So it was an active comparator. There was a 6-month follow-up, and that's what's published, and I'll show you the results. But a 12-month follow-up is still ongoing. I thought this was pretty cool, part of the study on that's a family affair. So what we're showing here, this is an actual account from one of the patrons. So I'm 45, I've always made sure my daughters go to the doctor, but I didn't make time to go to the doctor myself. I've been too busy providing for my family. And then he wasn't feeling well, and then his daughter got him to go to the ED, where the doctor prescribed medications for his hypertension. He was treated, and now he's going to work with his doctor to maintain control of his hypertension. And the end line is, I want to be there for my children for a very long time. So, a nice testimonial. Okay. But the cool thing they did in this is the pharmacist actually interviewed patients, got these stories, got the pictures, and they put them as a poster in the barbershops. So people that were coming into that barbershop knew the person that was in the poster and talking about what they were doing. So I just thought that was really phenomenal use of a testimonial. So that was sort of part of the intervention in the intervention group of the pharmacists. This is just a picture of the barber's blood pressure workstation. Okay, so this is where the blood pressure was monitored. The pharmacist took the blood pressure, but in some of the shops, the barbers were also trained to take the blood pressure. And there was monitoring, and the data were wirelessly transmitted back, which just made it easier and much more accurate to collect the data. Each one of the participants, whether they were in the active control or the intervention group, they had a little identification card that said they were in the study. And basically, they could go in and have their blood pressure monitored when they wanted. But there was an incentive in the intervention group, patients, patrons/patients. They did receive $25, which was to go towards the cost of generic medications or transportation. Each of them also, and there was also an incentive of, if you showed your card, you could get a free haircut in both of the arms of the study. So there were some incentives. So the pharmacist's role in the intervention group, they were to have at least monthly appointments in the barbershops with the patrons who had enrolled through an informed consent process. They would check the blood pressure. They were also working under a collaborative practice agreement, just as I mentioned about the original RightCare study. They modified drug therapy under that collaborative practice agreement. They monitored electrolytes using a point-of-care ISAT device. And then they would send a progress note to the patient's PCP. And the collaborative practice protocol was with the patient's PCP. So that took a lot of work. You had to identify who the patient's PCP was, go to that person, and get that collaborative practice protocol. For patients that did not have a PCP, one of the study physicians served as a PCP, and there was a collaborative practice protocol with that person. But I think that's a really key point, especially as I move you on to thinking the next topic of how do we engage community pharmacists with community PCPs and have that collaborative practice protocol. It's a hurdle. It's something that has to be worked out. Okay. So, that's a picture of the ISAT device. So another key important point of the intervention was, yes, it was a pharmacist who had prescribing authority, but there was a protocol of what was being prescribed. And the idea was to intensify the treatment of hypertension. So there were 3 steps. Step 1 was a channel blocker, calcium channel blocker plus an ARB or an ACE. And then step 2, thiazide type diuretic. And step 3, aldosterone antagonist. These were the suggested agents. They weren't always prescribed. It was up to the discretion of the pharmacist and what patients might have already been on. But this was the protocol that was followed. So baseline, there were 28 and 24 barbershops, and they had been in business for a long time, 17 to 18 years. The number of participants, 132 and 171. The average age, around 54 in each group. About 50% married, and household income less than 25%. Slightly more of those in the intervention group than the control. And again, just to remind us, these were only male patients. Any health insurance? I actually was kind of surprised at this. About 85% in both groups had some form of health insurance. Recognizing this was after the ACA was enacted, so this is fairly recent. Regular medical provider, about 80% did say they've had a regular medical provider. And these people had really been going to these barbershops for a long time, 10 or 11 years. There's a lot of trust that builds up over 10 or 11 years, I think. I think that was a really important part to both groups.